Hey guys, welcome to another episode of NasirMed. In today's video we will be talking about lupus or SLE. As you can see, there is a lot of information that we're going to go through in this lecture, so let's get things started. Alright, so let's start by talking briefly about the pathogenesis of lupus. Now, in normal individuals, when we get exposed to the outside stresses such as UV light, any chemicals in the environment, smoking, our body reacts to it by, or our cells react to it by undergoing programmed cell death or apoptosis. Now, once the cell lies, it will release all of its intracellular components. Now, in normal individuals, they will recruit those macrophages that will go to the site and kind of clear up all the intracellular components. However, in lupus patients, they are genetically predisposed to the accumulation of these intracellular components. Their clearing system is kind of delayed. And in particular, what we're interested in is those nuclear antigen that will be released from the cells, from the nucleus in particular, and they will start accumulating in the bloodstream. The immune system for lupus patients will kind of recognize that as a foreign body, and by the help of T cells and B cells, it will generate antibodies. These antibodies will bind to these accumulated nuclear antigen and will form these immune complexes. These immune complexes will then travel through the bloodstream to the end organs, start damaging them. This is briefly what lupus pathogenesis is all about. Now, lupus is common in females, it's common in middle-aged females, 15 to 65 years old, and it's common in the African American race. Now, the reason why it is common in the female over males, it's been theorized that it has to do with hormonal changes in estrogen in particular, but the exact reason is still unknown. Now, with lupus, it is very important for clinicians to recognize the early signs and symptoms of lupus early in the disease and treat it accordingly, because if you pick up this disease early in its course and start treating it, it can make a big difference later on in their life, and it can prevent them from having this end organ damage. It can prevent them from getting all those nasty complications that we're going to see that lupus can cause. Now, how would you pick it up early on is by knowing the clinical manifestation very well. So what are these clinical manifestations? Let's start by talking about the largest organ in the body, the skin, in what we call cutaneous lupus erythematosus. Now, cutaneous lupus erythematosus is divided to acute, subacute, and chronic. Now, in terms of the acute, is cutaneous erythematosus. This is what we call the malar rash that can present on the nose and on the cheeks. And the characteristics of it, and what helps you differentiate from the other similar rashes, is that it spares the nasolabial fold. Now, remember what other similar rashes that can present similar to the malar rash? You have the erysipelas, which is that cellulitis of the lymphatics of the face. It presents as a well-demarcated rash, more edematous, painful, caused by group A strep, and it can involve the nasolabial fold, unlike the malar rash. Another similar rash is the rosacea. Remember those telangiectasia, papules on the face. It can also involve the nasolabial folds. And remember dermatomyositis, this heliotrope rash that can present on the cheeks, on the nose, but also on the eyes. It looks a little more purplish and also involves the nasolabial fold. A malar rash characteristically spares the nasolabial fold, and it is most of the time the first manifestation of lupus. And if you present with the malar rash, 100% of these patients will eventually develop the systemic manifestations of lupus and develop SLE. That's not the case for the other stages of cutaneous lupus erythematosus. Moving on, talking about the subacute cutaneous rash, these are the annular and polycyclic patches with some central clearing in the middle, can sometimes have some scaliness to it, and it can present on the chest and the back area, the neck and the face, and around 50% of these patients will develop lupus. Moving on, talking about the chronic lupus erythematosus, the discoid rash. These are the nasty looking erythematosus or erythematous patches, and it has some scaliness in the middle of it. It can cause some skin scarring and atrophy, which is unfortunate to have. And once they heal, they actually leave hyperpigmentation on the skin. Now, the thing about this chronic lupus erythematosus or discoid rash is that only 20% of these patients will develop the systemic lupus. However, most of the time, 80% of the time, will be a discoid rash by itself. It will not it will not present with the other manifestation of lupus. So that's the difference between the discoid is like relative to the malar. The malar rash, 100% of them will develop lupus. Discoid rash, only 20%. That's something for you to remember. Now, that is it for the skin. Moving on to the involvement of the heart, most commonly pericarditis. Remember, pericarditis is a chest pain that is changes with inspiration and also worsen with certain positions. Now, other involvements of the heart is Liebman sac endocarditis. These are the non-infectious vegetations that can present most commonly on the mitral valve, and these vegetation can dislodge and reach to the brain and other parts of the body, can cause cerebral embolism. Another manifestation of the heart is the myocarditis. This is basically patient presenting with CHF-like symptoms. And remember, when it comes to the heart and lupus, lupus itself increases the risk for coronary artery disease by 2 to 10-fold. And that risk kind of increases if you put these patients on prednisones. So that's something always you have to keep in mind, that lupus patients have increased risk for coronary artery disease, and you'll have to watch out for them developing MI. Now, the next organ involved is the GI tract. They can present with abdominal pain. This abdominal pain can be explained by serositis, mesenteric ischemia, such as in patients with APLA, we're going to talk about in a second, and mesenteric vasculitis. Moving on, talking about the heme involvement of lupus, these patients can present with anemia. This anemia is normocytic and normochromic anemia. They can also present with thrombocytopenia. The thrombocytopenia can be very severe. The platelet can drop to even below 50,000. So that's something you have to watch out for. And also they can present with leukopenia or cytopenia. And a very common board examination here is, what is the malignancy that is most commonly associated with lupus? And the answer is non-Hodgkin lymphoma. They don't know what the exact mechanism is, why lupus patients are more prone to develop this malignancy, but they theorize that it has something to do with the overactivation of the B cells in these patients. So keep that in the back of your mind. Now, I want to touch base about antiphospholipid antibody syndrome here. Antiphospholipid antibodies present as women with multiple miscarriages, livedo reticularis on the skin, also can present with cardiac vegetations on the heart. And the characteristic, or like the unique thing about antiphospholipid antibody syndrome, is that it's one of the few syndromes that can present with both arterial and venous thrombus. Now, because of that, the medication or the treatment of choice for this syndrome is actually warfarin. It is superior over the other anticoagulants in this case because it's been shown to be more effective in both arterial and venous thrombus over the other anticoagulation alternatives. Now, to diagnose antiphospholipid antibodies, you have three antibodies that you need to order. If one of them is positive, that's kind of diagnostic for the disease. Now, however, if 3 of them are positive, and what we call triple positivity, APLA, that has the highest risk of thrombus formation, and that can be the most severe form of this syndrome. So that is it about antiphospholipid antibody syndrome. Moving on, talking about other organs that can be involved, such as the brain, lupus cerebritis. These patients can develop altered mental status, headache, confusion, and when you do a lumbar puncture on these patients, you'll see an elevated protein level, and when you send this fluid to the microbiology lab, it can be positive for anti-NMDA antibodies and anti-ribosomal P. And remember, these patients, because they're presenting with this altered mental status, confusion, you really want to get a CT or MRI just to kind of rule out other causes of this manifestation or this picture. Now, moving on, when you suspect lupus, always remember to look at the oral mucosa, because these patients can have ulcers on their hard palate. Now, these ulcers are painless. I want to emphasize painless because they can present similarly to the office ulcer. But the difference between lupus ulcer and office ulcer is the office ulcer is painful, lupus ulcer is painless. So make sure you watch out for that. Now, the next organ that is involved is the lung, and the most commonly presentation is pleuritis. And when they develop pleural effusion and you do the thoracentesis, they will have that exudative effusion with a lot of lymphocytes. And when it comes to lung involvement, you want to watch out for 2 complications. And these are very serious complications because they have a high mortality rate, almost above 50%. Mortality rate in these patients. So what are these 2 complications? One is diffuse alveolar hemorrhage and one is acute lupus pneumonitis. Talking about diffuse alveolar hemorrhage first, these patients can present with dyspnea, hypoxia, cough, hemoptysis. When you do a CT scan of their chest, you will see infiltrates on both sides of the lung, and on their lab you'll see that drop in hematocrit and also increase in DLCO. These are characteristics of diffuse alveolar hemorrhage, so you'll really have to keep an eye on that when you're dealing with patients with lupus. The next complication is acute lupus pneumonitis. This can present very similarly to infection or pneumonia, as it manifests as fever, cough, hypoxia, dyspnea. They can present with also infiltrates on both sides of the lungs on a CT scan, and often hospitalists confuse that with pneumonia, and these patients normally treated with both steroids and antibiotics, and hopefully one of them will do the trick. So that's it in terms of lung involvement. In terms of the joints, they can present with lupus arthritis. Lupus arthritis mainly affect the small joints, such as your fingers, the wrist, the elbows, and it is non-erosive type of arthritis, unlike rheumatoid arthritis where it is erosive type of arthritis. Now, the complication when it comes to joints and lupus that we really have to keep an eye on is osteonecrosis, and that commonly affects the hip and most commonly affects patients who have severe lupus and they're on a high dose of steroids. Now, I mentioned it most commonly affects the hip, and they present as severe hip pain and decreased range of motion secondary to the pain. And the image of modality, and this is the important board question, depends on how early the symptoms are. If the symptoms present very acutely, it's been there for just few days or few weeks, then you can order MRI because the x-ray will not show much. However, if the symptoms has been there for weeks and months, then the image of choice will be x-rays, because x-ray will be enough and will be more economic options in this case. Now, moving on and talking about the most valuable organ in lupus, and the one that we really care most about when it comes to treatment of lupus, and we really aim to save in these patients is their kidney, what we call lupus nephritis. Now, when these immune complexes that I mentioned reach through the bloodstream to the kidney and start to deposit themselves in the kidney, in particular in the glomerulus, based on where they deposit themselves and what's the extent of this deposition, we classify lupus nephritis from class 1 being the most mild and class 6 being the most severe, which is the end stage level. Now, once these immune complexes start to deposit first in the mesangial area, that is classified as class 1 and class 2. Now, with this class, it is very mild. You will barely see any proteinuria or hematuria, probably +1 if any. Now, once these immune complexes start to deposit in other areas, such as the subendothelial layer, and that's very close to the bloodstream, so once they start deposit there, you will start to see more hematuria, more blood being thrown into the urine, and you'll also start to see more proteinuria as well. And moving on to class 5, which is very unique. Once these immune complexes start to deposit themselves in the subepithelial layer, this becomes a problem. The reason is the subepithelial layer is very close to the basement membrane, and the basement membrane is very valuable part of the glomerulus, and it is the main barrier to all those proteins from leaking out into the urine. So once the immune complexes started depositing there, that will cause damage to this basement membrane, and you'll start to see leaking of significant amount of protein in the urine, +4. Now, what's unique about this stage is that sometimes patients skip through all these 4 stages, and their immune complexes is only deposited in this layer. And if that's the case, you will only see proteinuria but no hematuria. And this is what we call nephrotic syndrome. So patients with lupus can actually present with only nephrotic syndrome, not going through the first 4 stages, the nephritic syndrome first. And in this case, we call it membranous nephropathy. And however, they can also present as a progression of all those stages, and in that case they will present with severe proteinuria and severe hematuria as well. And once they start depositing more than 90% of the glomerulus, that's what we call class 6, and this is end stage level, and in that case your choices will be hemodialysis or kidney transplant in that case. Now, when you suspect lupus nephritis with the urine analysis, you see that proteinuria, you see that hematuria, it is not enough for you to say yes, these findings are secondary to lupus nephritis. It's not enough for you to say that until you get the biopsy. And the biopsy will also help you stage that lupus nephritis, know where you are in terms of the classes, and based off that, it will tell you how aggressive you want to be in terms of the treatment. And remember, with lupus nephritis, the kidney starts failing, you'll start to see more edema, hypertension, all these other manifestations that the patient can present with. So this is it in terms of the clinical manifestation of lupus. Now moving on, talking about the next section or presentation today, talking about the diagnosis of lupus. So remember that the diagnosis of lupus is clinical diagnosis. You really don't need a certain guidelines in order to confirm your diagnosis. It's based on your clinical suspicion, and of course with the help of the lab work as well, and the biopsy results from the lupus nephritis as well. Now, however, there was previously used guidelines. It's called SC or SLICC. That was dated back in 2012, and these guidelines has 17 criteria that if you meet 4 of them, that kind of diagnostics of lupus. Or if you have a biopsy proven lupus, that's also enough to make the diagnosis. However, what they notice is that this guideline has a specificity in the 80s. Yes, a sensitivity in the 90s, but its specificity was in the 80s, which was the downfall of this guideline. So they came up with a new one last year, it's September 2019, and they called it European League of Rheumatism and American College of Rheumatology, and I'll put the link for it down below. And this classification starts with an entry criteria. The entry criteria is you have to have a positive ANA of a titer of 80 and above in order for you to be considered in this classification. And once you have that, there is a table full of the different manifestations of lupus and the lab results that it can have, or the biopsy results, and there's a score beside each one of those. And if you calculate your score and it's 10 and or above, then this is diagnostic of lupus. However, there is also a downfall of this classification. There is a downfall and there is advantages. The advantages thing is that this criteria has gained its popularity recently because it has a specificity higher than the old criteria that's been used. The specificity is 93%. However, the downfall of this criteria, and the reason why it's still not officially used to diagnose lupus, is that not all the patients with negative ANA will be lupus free. Actually, ANA is 95% sensitive, meaning that there are 5% of patients that will have negative ANA but still have lupus. And that's the main reason I said lupus is still a clinical diagnosis. You can't 100% rely on these classification, but you can still use it to kind of raise your suspicion. Now, moving on, talking about the lab work that we can order for lupus, when you suspect lupus, order a CBC to investigate in this anemia, thrombocytopenia, leukopenia. Also order CMP to look at the kidney function, the creatinine, the AST, ALT involvement. You also want to order urine analysis to see if there is any hematuria or proteinuria. And also, as I mentioned, order the ANA. It is sensitive, yes, but it's not so specific. If you have a positive ANA that doesn't still tell you that this is lupus, you'll have to order more confirmatory and more specific antibodies. These antibodies are anti-double-stranded DNA, anti-Smith, anti-RO, anti-LA. And you also want to order complement levels such as C3 and C4. And the complement levels, along with the anti-double-stranded DNA, these are the activity markers for lupus. Now, once you start these patients on therapy, you want to monitor the anti-double-stranded DNA and the complement level to kind of see if your therapy has been effective or not. And also you want to review their medication list, because a lot of the medications that we put these patients on can actually develop lupus. Some of the most common ones are hydralazine, that's also very commonly used in the inpatient settings, procainamide and isoniazid. So you really have to watch out for that. Now, moving on, talking about the last section of our presentation, which is the management. The number one medication to treat lupus with is hydroxychloroquine. The reason it is number one is that it first improves symptoms, it also reduces the flares, and it also saves the end organs from being damaged, and it improves the overall survival. Now, the advantages of this medication is that it is safe to be used in pregnancy, and it doesn't cause any bone marrow suppression, and it doesn't have any hepatic or renal toxicity. There are side effects of this medication. As we all know, it can cause retinopathy, and that's why you have to refer these patients to ophthalmologists once you start them on this medication. You refer them to see the ophthalmologist at the time or before you start the therapy, and then 5 years after the therapy, after being on the therapy, the hydroxychloroquine, and then annually afterwards. Now, the hydroxychloroquine, the dose normally used is 200 to 400 PO daily, and you have to remind patients that this medication takes time. Some studies have shown that it actually takes up to 2 months for hydroxychloroquine to be effective. That's why you have to remind patients to be patient when they're on this medication. Now the next thing is steroids, and as you know, steroids are the #1 medication when it comes to treating flares of lupus. The dose depends on how severe this flare is. Ranges from just 10 milligram PO daily to putting them in the hospital and starting them on IV steroids. And once you start them on that and you start to see improvement, you want to kind of taper down this steroids and eventually wean them off if possible. And as you all know, the nasty side effects of the steroids: weight gain, Cushing-like symptoms, hyperglycemia, and the list goes on. Now, for refractory or severe cases of lupus, you want to start them on immunotherapy. Immunotherapy is composed of two different parts. One is induction and one is maintenance. Induction is what you need to start them on when they're having this flare. And you have two medication of choice when it comes to induction immunotherapy. One is cyclophosphamide and the other one being mycophenolate. Cyclophosphamide, or I should say mycophenolate, has gained its popularity over cyclophosphamide. The reason is cyclophosphamide have these nasty side effects that nobody wants to have, such as hemorrhagic cystitis, such as ovarian dysfunction. And remember, most of these patients are young females. They want to still have babies, so you really want to save these ovaries and not, damage them. And that's why mycophenolate has been more commonly used. When it comes to, once their flare stabilizes, you want to switch them to the maintenance therapy. In that case, you have two choices that are very commonly used: mycophenolate and azathioprine. And azathioprine, among all the immunotherapy, has been shown to be the safest when it comes to pregnancy. Now, last but not least, is the only approved biological agents to treat lupus, has been shown to be very effective in the latest studies, is belimumab. It's recently gained its popularity, and the studies are still under process on this medication, and probably in the next few years we will start to see it being used more often. Now that is it for what I have on the board. There are 5 things that I want you as a physician to remind patients who have the diagnosis of lupus of. The first thing is remind them to avoid the excessive sunlight and apply sunscreen when needed. Second thing, remind them that to quit smoking if they're smoking, as smoking has shown to be a trigger of lupus. Third thing, monitor their sugar level, monitor their cholesterol level, and encourage them to exercise and maintain a good diet. Remember, I told you here in the cardiac section that lupus increases coronary artery disease by 2 to 10 folds. So you really have to monitor these kind of things to kind of reduce the risk of coronary artery disease as much as possible. The fourth thing is about vaccines. Lupus patients can have the same vaccines as a normal, healthy individual. However, the only difference is that if they are on aggressive immunotherapy, you really have to be careful when it comes to live vaccine. And the fifth thing, and the most important one, is educate these patients about the severity of this illness. Educate them that with treatment, it really can make a big difference. And especially that studies have shown that without treatment, patients can progress to the end-stage renal disease in a matter of 2 years. So it's really important to tell these patients to be compliant on these medications, as it can make a big difference later on in their lives. And that is all what I have today for our presentation. Thank you for watching and enjoy the rest of your day.